Spinal tract overview is where we are now. Okay. And this is pretty straightforward. As far as the overview is concerned, I'm drawing the midline so we can see where things decusate. Okay. And we want to add a little bit of definition to my medulla here. I'm going to draw in my little bumps. So it's going to be the olive and the pyramid. There's my olive and my pyramid there. Okay, I'm going to start from the other side. So in the M1 area, we have upper motor neuron cell body here, neuronal cell body, going to send out axons that travel down through the internal capsule, through the midbrain, through the pons as your corticospinal tract. Okay, when they reach the pyramids, 90% of those axons are going to decusate to the opposite side. Okay, those axons are then going to travel down as the lateral corticospinal tract, make a synapse at the appropriate spinal level with their lower motor neuron that resides in the ventral gray horn and innervates skeletal muscles. Okay, so here's your lower motor neuron traveling down here. After we decusate, that's your lateral corticospinal tract. Okay, here, traveling down is just your corticospinal tract, so axons coming out of that lower motor neuron. And then way up high here, we have the upper motor neuron cell body. Okay. Very straightforward. Yes, Alex?
Is there any reason why you drew it on the other side?
Yeah. Change it up a little, you know, I get bored. No reason, just to show it's on both sides. It's the same thing on both sides. There is no difference. Okay? Any other questions? Yes, Ellie?
Is that all just one neuron? It's not as different.
It's an axon.
Axon.
Yeah, it's only one axon. That axon comes out of this upper motor neuron cell body, travels straight down until it gets to the level of the pyramids, decusates, and then comes down. This is just one. Remember, the motor system is a two-neuron system. You have your upper motor neuron and you have your lower motor neuron. That's it. First order, second order, third order, or your somatosensory. That's a three-neuron system. This is just two neurons. That's it.
I like that.
Simple, right? Better than a million. Any other questions? Okay, let's keep moving on. Let's look at the next one is going to be your brain stem, your brain stem descending tracts. And these are nothing more than what we looked at previously. We're going to look in more detail here at the cerebrospinal tract, vestibulospinal tract, and reticulospinal tract, and how they decusate, if they do or not. Where's my black? Black. No black one? I don't see it. Okay. It's really weird. I'll use blue. Looking at this is going to be my midbrain. Just my basic brainstem. Here's my cerebral aqueduct. Okay, come down, I have my pons and my medulla. Okay, all the basic parts of the brainstem. Might as well draw in a few things while I'm here. have my lateral corticospinal tract. We talked about that. 90% of axons decusate and travel down the lateral corticospinal tract. Okay, way back when we drew the cross section of the spinal cord, we also have right underneath your lateral corticospinal tract, you have a little tract here. This is your rubrospinal tract. I think I did them in purple before. Now you have your anterior corticospinal tract here. Okay, and bless you. And then you also have a few others that we talked about before. Was on the bottom. It starts with a V, so that's how I remember it's on the bottom in the anterior column. It's going to be your vestibulospinal tract. And just above your vestibulospinal tract is going to be your reticulospinal tract. This funky orange.
What was the orange one?
This is your vestibulospinal tract. And then just above that is your reticulo. Okay, so that pretty much sets up all players. Another thing I can do is put my lower motor neurons in here. So I know that more dorsally, my lower motor neurons are going to be flexors. I'll put that on both sides. And then more ventrally, I'm going to have lower motor neurons that are extensors. Proximal musculature is represented more medially, and distal more laterally. Okay, everybody got it? Let's look at, yes, Josh?
What are the blue ones called on the bottom?
This is the anterior corticospinal tract. Try to make them purple. Any other questions? Yeah?
On the body, like which side is right and which side is left? Like we're looking.
You can say this side's right and this side's right and this side's left. You want me to label that? I can. I lost my little black Sharpie. But, all right, this side, yeah, let's make this side right and then this side left. Is that what you want? Okay. And having said that, let me go ahead and, this is my midline coming all the way down. I just like to know when things cross over and when they don't. Okay. Any other questions or?
I'll just
Okay, now let's think about up here in the midbrain. We have this big old nucleus. It's called your red nucleus. Red nucleus is going to be the start of the rubrospinal tract. The red nucleus is going to send out axons that decusate immediately in the midbrain. Then they're going to travel all the way down. Okay, and when they're traveling in the spinal cord, they're traveling through the rubrospinal tract. Yes?
Is it, I guess it's safe to assume there's a red nucleus on both sides of it?
Yep, red nucleus is bilateral. Yep.
Is it synapsing on the rubrospinal tract? Or
It's traveling. It is.
It's feeding into it. It's just the same axon?
The rubrospinal tract itself is made up of all the axons coming out of the red nucleus. That's the tract. All those axons are traveling together. So remember, common origin, common destination. They all start at the red nucleus, and they're all going to end in the spinal cord. Okay, that's the red nucleus, or the rubrospinal tract, that tract. Any other questions? Okay, so they're traveling down here, and when they get to the appropriate spinal level, then the axons are going to come out, and they're going to synapse, and I'm going to make it specific synapse here on elbow flexors for the red nucleus. Remember, elbow flexion, rubrospinal tract. And that's elbow flexors. Okay, so just like the corticospinal tract, the rubrospinal tract decussates. However, it decussates at the level of the midbrain, right when it starts. Yes?
Just to clarify, this is specifically
The rubrospinal tract, that's just think elbow flexion. That'll help you later. There are other jobs of the red nucleus that we'll talk about when we get to the cerebellar. But for right now, you just think elbow flexion. You're good. Okay? Very different than the others. Any other questions? In humans, the red nucleus is involved in elbow flexion. Okay, moving on down, we have, oh, that's orange. Oh, good. I did orange. So here's at the level of the caudal pons. I have this nucleus here. That's your vestibular nucleus. Okay. And your vestibular nucleus sends out axons that don't decussate. They're just going to stay ipsilateral, and they're going to travel through this vestibulospinal tract here at the bottom. Okay, once they reach their appropriate spinal level, then they're going to synapse with a lower motor neuron that's involved in extensor musculature. Okay, extensor. So here this elbow flexor sends out axons specific for elbow flexion. Well, let's go ahead and say this one, just for the sake of argument, is for glute max. Okay, major postural extensor. Okay, extensor is going to be on the bottom, and that's more proximal. Okay, and then the last tract, I think I used pink before. The last one that we'll have to consider that also stays ipsilateral, there's a diffuse body of nuclei here in the medulla. Okay, that's your reticular formation. Reticular formation sends out axons that stay ipsilateral. They travel on down the spinal cord in the reticulospinal tract and come out and synapse with extensor muscles here on the bottom. Okay, I was thinking about an extensor muscle a little bit more lateral, so we want just a little bit more distal, so glute max, and then do you want to think knee extensor? Okay, how do I do that? So here, let's just say quads. Okay. So there you have all the other brainstem descending tracts in addition to your corticospinal tract. So red nucleus, responsible for controlling elbow flexion, and vestibulospinal and reticulospinal are involved in innervating postural extensors. Vestibulospinal tract active in response to changes in gravity. Reticulospinal tract more active when you're conscious awake, not sleeping. questions? Yes, Hannah?
I think I'm just confused, cause one is upper body and one's lower body. Is it just like,
Just examples.
just examples? Okay.
Just give an example. That's
Okay.
all. Yeah, don't, like I said, they synapse at the appropriate level, okay, the appropriate spinal level. So, but drawing it, I try and keep it as simple as I can. Just making sense. Jeff?
Maybe you've already explained this, and maybe this is just too far ahead, I don't know, but like, what is the difference between like the red nucleus and the particular spinal tract? Like, how do you differentiate between the two?
So how do I differentiate?
Sorry, the two extensor ones.
How do I differentiate between them? Really one way they're different is they're in different positions in the spinal cord, okay? Another way they're different is the vestibular spinal tract starts out of the vestibular nucleus, okay? And the reticulospinal tract starts out of the medulla and the reticular formation. But to activate them, reticular formation is involved in sleep-wake cycles and awareness and consciousness. If you have a patient post-brain injury, they might not have that. Okay, they might be in a coma. They might not be awake. However, even if that person is in a coma, I know I can get them upright against gravity, and I can use the vestibulospinal tract to activate their sensors. It just works.
Really?
Yeah, that's how you do it. Does that make sense as to why they're two different things? Reticulospinal tract is involved in, if you're awake and aware, you can think that you want to be upright against gravity. The best example is if you fall asleep standing up, you're going to fall over because you're not awake. Okay? But I can use the vestibulospinal tract clinically to activate all your sensor muscles, even if you're not awake.
That's super cool.
It is super cool. It works. It's one of my favorites. Any other questions? Okay, let's move on. Keep going. Now we're up to the super simple stuff. I know I've talked about it. I know I've drawn it. But there's some other things that you need to know as far as upper motor neuron injury specifically is concerned. Okay, we've talked about the neuronal cell body for, so let me draw it. So here's my lateral corticospinal tract here. All right, in the spinal cord. And I'm going to have my lower motor neuron cell bodies here in my ventral gray horn. Lateral CST, okay, and then this is a lower motor neuron cell body. It's also known as an alpha motor neuron. Okay, did everybody get that before I moved it? So just drawing in my lateral corticospinal and my lower motor neuron cell body. Okay, and then things that we talked about previously, here sitting in M1, here's my central sulcus, sitting here in M1, and it's a side view, sagittal view, so I'm not going to be able to see the decussation. But I know that this upper motor neuron, this is my upper motor neuron cell body. Okay, that's going to send out an axon, travels all the way down the spinal cord. Okay, it's going to decussate. I'm not going to differentiate left from right because we're not going to watch the decussation for right now. Okay, and then it's going to travel through the lateral corticospinal tract in the spinal cord, and its appropriate spinal level, it's going to come out and synapse with the lower motor neuron cell body. Okay, and that lower motor neuron cell body sends out axons that are lower motor neuron. Right? We've been doing it all day, showing it all day. Now, what you need to know here that's going to be really important next year, you know, we're going to spend a whole half a semester on the difference between an upper motor neuron and a lower motor neuron injury, okay? If there's an injury here, anywhere along the path of this upper motor neuron axon or to the upper motor neuron cell body, that is called an upper motor neuron injury, okay? So, things that you need to know. This is an upper motor neuron injury. signs and symptoms. Okay, signs and symptoms of a patient with an upper motor neuron injury. Think they've had a stroke, right? What kinds of signs and symptoms? One thing that you could see, if this were injured during the stroke, anywhere along here, were injured during the stroke, you would see paralysis or paresis, let's just say weakness, right? Okay, that's one thing. And in the very beginning of, so let's say the first month or so, first 2-3 weeks, you might see what's called hypotonia. That means they've lost their muscle tone. There's really no muscle tone in their arm. More flaccidity, right? They don't have a lot of tone there. Okay. And in the beginning, you'll see also hyporeflexia. Okay, hyporeflexia or areflexia. That means there's a reduced reflex. We'll get to reflexes in a minute, or an absent reflex. Either one's possible. Okay, that's in the beginning. And then as time progresses, they may change over to something else in these two categories. The paralysis or paresis is going to stay, but if you're an upper motor neuron injury, or if you see hypertonia, that person that started out hypotonic could become hypertonic, increased muscle tone, spasticity, rigidity, lots of words for it, or hyperreflexia. So in the beginning of time, post-stroke, you'd almost expect a hypotonia or a hyporeflexia, but over the course of 2 weeks or so, that person may progress to hypertonia or hyperreflexia. Okay? That means if you have a clinical presentation or a person with clinical presentation in front of you with neurological injury, if you see hypertonia or hyporeflexia in that patient, you're thinking upper motor neuron. That's what that means. Okay? Nothing more. It's that simple. What? Is there a question? No. Question? Nope. Does that make sense? Pretty easy, right? We'll see. Come back to it next year. That's the upper motor neuron, okay? And then the other one is the lower motor neuron. So same exact pathway, right? We've got your upper motor neuron. We just did all this. We have your upper motor neuron sitting here in M1. It sends out axons that are going to travel through this lateral corticospinal tract here. Okay. And then you have your lower motor neuron cell body sitting here in the ventral gray horn that innervates skeletal muscles.
Can you move it up a little?
Mm-hmm. Better?
Yep.
Thank you. Okay, so this here is your upper motor neuron. Okay, that axon's traveling down through the lateral corticospinal tract. The appropriate level comes out in synapses with the lower motor neuron. Okay, so this is your lower motor neuron. So it is a peripheral nerve, even though the cell body itself is actually in the ventral gray horn, which is part of the spinal cord. That's the lower motor neuron start. Okay, the lower motor neuron is a peripheral nerve. So that's the cell body of the peripheral nerves. Is housed here. Okay, if there is an injury anywhere along, whether polio could take out that alpha motor neuron, or like think a nerve root injury here, or a muscle, a neuronal axon is cut or something, or damaged, like carpal tunnel. That's all lower motor neuron injuries. Okay, the clinical presentation for a lower motor neuron. What did I do before? I said So I have, this is going to be lower motor neuron injury signs and symptoms, okay? And this doesn't change. But there's a few words here that if you see these things happening, you know it's a lower motor neuron injury. And you know what that means now, right? That means that anywhere along here has been damaged. Anywhere, whether it's here or anything outside, that's a lower motor neuron. Upper motor neuron's fine. Okay, they're similar in that a lower motor neuron injury, you can have paralysis or paresis. Okay, you're going to have hypotonia, and that won't change no matter how long after injury. Patient may present with hypotonia. They may present with hypo or areflexia. That just means they don't have a reflex. Okay, and the two ones that we haven't heard before with upper motor neuron, that if you see these two words, that means it's lower motor neuron injury. They are atrophy. You see somebody with atrophy, you know it's a lower motor neuron injury. And if you see someone with something known as fasciculations, 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 lower motor neuron injury. Okay? And fasciculations are nothing more like muscle quivering. We'll see a picture later on when we get to the cranial nerves. But fasciculations, it's just like a quivering of the muscle, pretty continuous. It doesn't start and stop, it's always quivering, just a little bit. That's indicative of a lower motor neuron injury. Two presentations. Upper motor neuron, if you see hyperreflexia or spasticity or hyperreflexia or hypertonia, upper motor neuron. Okay? If you see fasciculations or atrophy, you're thinking lower motor neuron. That's simple. Hannah.
Where's the point where it's considered the lower injury again?
This is the neuronal cell body of the lower motor neuron. That point, anything happens to that cell body or any of the axon that's coming out to innervate the skeletal muscle, that would be considered a lower motor neuron injury. Think carpal tunnel. There's.
Sciatica?
I'm sorry?
Sciatica, example of lower neuron injury?
Sciatica could be, yeah, the sciatic nerve is somehow tethered and it's becoming damaged. That could lead to a lower motor neuron injury. It's damage to the nerve itself.
Rather than irritation or
Any kind of damage to the nerve, that would be a lower motor neuron, peripheral nerve root injury. That's another one. Has everybody got that? Yes, you.
What would be different between hypotonia and atrophy specifically?
Oh, atrophy is where you see muscle wasting. So if you were comparing sides bilaterally, one side would have visibly less muscle mass than the other. Hypotonia is a feel, so when you do passive range of motion with somebody, I can feel how much tone you have in your muscle. It's like that feeling. It's like you're either, you've got normal tone, you've got less tone, or you got more tone.
Okay, so it's like if it's firm or not for tonicity, and then if it's being nourished or not for atrophy.
So what was it? If it's firm, yeah, the
If it's
firmness,
firm or
okay,
soft,
firm
there's
tone,
then-
yeah, sure.
And then if it's getting
Atrophy-
like nutrients, if it's like a live tissue essentially, that's getting enough nutrients to be like that, it's atrophy or not.
Yeah, no, it's not. So the tissue itself is alive. It's that the nerve innervating it isn't firing. So it's reduced muscle mass over time. So for example, if you were wearing a cast, yeah, I don't know if you ever wore a cast. You wear a cast. You're stuck. Your arm's stuck in this position. You haven't used any of this musculature for a long time. Tissue's still alive. Everything's good. But when they take that cast off, my arm's going to look a lot different. It's going to look a lot smaller. Lack of motion. Okay, lack of active muscle firing is going to cause atrophy.
Thank you.
You're welcome. Any other questions? Okay, good. And let's just look at reflexes real quick. And we'll move on. This guy, this is my little stick man. You guys cover reflexes in anatomy? Did you cover reflexes in anatomy? No? A few. There's only a few to cover. Okay. So this is what you do. You'll learn how to do this in CP3. right? Take your little reflex hammer, and we talked about the myotatic stretch reflex. This guy indicates what the reflexes are. Okay, so bless you. This is going to be my triceps reflex. What nerve root level is triceps? Anybody know? C7. Yeah, good. C7. And then opposite triceps. I'm just going to label one side. This side's going to be the same. Okay. Opposite triceps is going to be your biceps reflex. Biceps is going to be C5, C6. And then coming on down here, this is the forearm part. Say brachioradialis. Okay, and that's going to be C6. Easy one. This one here is going to be your patellar reflex. Patellar reflex is L3, L4. And just one more. Here's your, bless you, Achilles reflex. Bless you. Achilles reflex is going to be S1. Yeah, and when you actually test somebody's reflexes, you test them bilaterally, and you're looking for changes from normal. Okay, as far as a reflex scale is concerned, you're going to grade it 2+ if it's normal. Okay, so somebody with a 2+ reflex is going to be considered normal at any of those testing sites. Okay, if it's greater than 2+, so anything greater than 2+ is going to be considered hyperreflexia, reflexic, anything you want to say. Greater than 2+. So if you grade the reflex as 3+, you're indicating that that person has hyperreflexia. Okay, well, 2+ is normal, and 2+ is greater is hyper. 1+ is going to be hyporeflexic. And then a great big old 0 is areflexic. That's it. Said you'll learn how to grade. Oh, yeah. So if I had to go through and I had to label these these reflexes, what you'll see when you see stickman is you're not going to see the words here. What you're going to see is something like this: if everything is normal. Okay. So if somebody were hyperreflexic, I might see a 3+ here, or 3+ in some different places. Hypo. It's just indicated where you know the word should be. Yes, Silly.
Does hyperreflexic kind of correlate with like being hypotonic and
Hypertonia and hyperreflexia are both indicative of an upper motor neuron lesion. Yep. That means they're the same. They go together. They're both part of an upper motor neuron lesion. Okay. You see hyperreflexia, hypertonia, upper motor neuron. Okay. All right. I also have